One of the highlights of EASD is the Claude Bernard lecture. It's a very prestigious lecture. It's been given by some of the greats in the diabetes world. And I'm delighted and deeply honoured, actually, to be able to interview Steve Kahn, the person who gave the Claude Bernard lecture this year. And if I might call you this, the king of the beta cell.
Well, that's very kind of you. I think that's a little over the top for me, but that's fine.
One of the things that strikes me most about you is that you've been rewriting the diabetes textbooks for really quite a long time. And your lecture took us through the whole sweep of your work. So let's start first with the beta cell.
Sure. So again, you're really generous. I wouldn't say that we've been rewriting the textbooks. The first thing I think one should acknowledge is I get to give the lecture on behalf of a host of people that it's been my absolute honor and joy to work with, from trainees to collaborators in Seattle, where I have worked at the VA Puget Sound and the University of Washington, as well as people from all over the world. I think what we really did and helped us define all of this is that some 25 years or so ago, the dogma, certainly on the side of the Atlantic that I live in America versus here in Europe, but probably across the globe, was that insulin resistance was the reason people got type 2 diabetes. And by looking at beta cell function in a somewhat different way, where we accounted for what the cell was being asked to do and how it was responding to that, we were able to demonstrate that when individuals become insulin resistant, for example, they develop obesity, or they stop exercising, or whatever it may be, you will see that with that insulin resistance, if their beta cells are normal, their insulin secretion will simply increase to compensate, so everything stays homeostatically intact. And that in individuals with what we might call nowadays pre-diabetes, at that time we really called them IGT, or impaired glucose tolerance, and those who ultimately have type 2 diabetes, there's this progressive reduction in beta cell function when you account for differences in insulin sensitivity. And when we showed this relationship and this happening, I think it helped change the focus of where people were thinking that you had to look at these two in combination versus one over here and another one over there. And because people with diabetes or pre-diabetes were more insulin resistant than healthy controls, the argument was that's why you get it. But really, once you accounted for resistance and matched that, all that fell away and you were left with the beta cell as a problem. Now, when we did that work, most of the people that we studied were either Caucasians or Asian Americans. And what we were subsequently able to demonstrate using larger study cohorts that we were part of was that this was a similar process in the US, at least, in African Americans, Hispanics, and most importantly, I think at the time, was demonstrated subsequently by the group in Arizona that in the Pima Indians, the Native Americans, the same process occurred. The beta cell was failing. That's why glucose was rising and these individuals were developing type 2 diabetes.
So you've got beta cells trying their darndest to work harder, but failing. What implication has that knowledge had in terms of the drug regimes that we have currently?
So what is interesting about that, I think, is as you start to look at studies that have been performed in the last 10 to 15 years, which have been driven in large part with the development of new agents, so there's new opportunities. From one of those studies that we did back in the mid-2000s called ADOPT, we were able to show from the analyses of glucose control in terms of hemoglobin A1C, but even more from taking looks at beta cell function using an oral glucose tolerance test, we were able to see and really show, I think, for the first time, differences in outcomes in terms of glucose and beta cell function in people who were recently diagnosed and who had not been on therapy before. And what we found was that the sulfonylurea representative in this group, which happened to be glyburide or glibenclamide, depending on where you live, had the best effect to initially lower glucose in terms of hemoglobin A1C, but subsequently the rate of progression or the slope for the increase in hemoglobin A1C was steeper than what we saw with metformin and even steeper than what we saw with rosiglitazone. And then when we did the analyses looking at beta cell function from the oral glucose tolerance test, what we found was that the drugs that produced the better, what we call durability, the metformin and rosiglitazone, not only improved insulin sensitivity, but I would argue sort of afterload reduced the beta cell. In other words, reduced the workload on the beta cell so that the sick cell didn't have to work as hard as with the sulfonylurea, which was pushing it to work harder. An analogy that I didn't use in my lecture, but which would fit this, would be an elderly individual who needs a walker to get around. And you then ask them that the traffic light is about to change, they need to run across the street. You give them the walker, ask them to run harder, and the poor individual who's representing the sulfonylurea is going to crash and burn because you ask them to work harder than allowing them to slowly walk across the street because you brought them there when the pedestrian crossing changed to green and they had more time to meander across and they survived better. So I think reducing the demand on the beta cell is probably the way to go. And what's interesting is that when you look at all the outcomes with bariatric surgery, everybody talks about this as the new approach, it's more durable. It absolutely is more durable, I totally agree with that. But even over time in those individuals, you see the hemoglobin A1C creeping up, you see the need for introduction of medications again, so that even with large amounts of weight loss, we still see progression of beta cell function and failure. And to me, that's one of the critical questions that we have to work on now. Why is that happening? And I would also say that we need to look to the future to see whether other drugs that work on the beta cell, such as the DPP-4 inhibitors, the GLP-1 receptor agonists, or when it gets even further down the road, combinations of drugs that are peptides that might stimulate the beta cell, whether that actually works out to be good or not. And I think that's the next thing we need to learn from longer-term information.
So is hemoglobin A1C the right measure for us to be looking at all the time?
In the clinic, I think it is the right measure. From the point of view of the physiologist like myself to understand what's going on, no, I think you need to do more because it's just an integrated measure of glucose as an endpoint of something that's upstream of glucose. But absolutely, I think at the moment, from a clinical point of view, hemoglobin A1C is still the way to go.
Finally, you were also talking about the way that we have diabetes developing in youth and then morphing into adult forms, and that was particularly interesting. Take us through some of that work.
So I've been really fortunate that I was asked by the National Institutes of Health in the US to chair a multi-center study of 7 centers that did some sort of feasibility studies to try and see if we could find ways to improve outcomes in terms of beta cell function in both youth and adults for 2 reasons. The one is that in adults, we know from studies such as the Diabetes Prevention Program, we can slow the progression of diabetes, but we don't stop it. So is there something better? That was one question. And the other reason was that in youth, which we're seeing now in the United States, in particular with a study called Today, that these kids are getting diabetes that looks like the diabetes in adults, but they're not doing very well. And so what we did in this study called the Restoring Insulin Secretion, or what we fondly know it and advertise it as, is the RISE study, and there have been many publications already that have come from this now. We asked the simple question, can we improve beta cell function and maintain that improvement with an intervention and after a 3-month period of washout? And we had a 12-month period that we did this. And what we did in these kids and adults is hyperglycemic clamps, which we could, sophisticated measurements, which we could use to determine insulin sensitivity and also look at beta cell function. And we added to them an additional approach with an injection of arginine that allowed us to look at the capacity of the beta cell to respond to a stimulus. What was really wild for us is that when we looked at the baseline data to start with, we would have predicted that the kids might look like the adults and fall on a similar curve, which I talked about in the lecture, this concept of curves and moving up and down curves or falling off curves, that we would see them on a similar curve. And lo and behold, we were blown away to find they have their own curve. So that at any matched degree of insulin sensitivity, the kids' beta cells are hyper-responsive. In other words, they're secreting more insulin. Why is the $64 million question? If you get that answer, I think you're going to have real clues as to what we should do for them and how we could treat them and potentially treat adults. We need to get to the bottom of that. We do not know why they were hyper-responsive. But what we also found is that when you intervened in them, giving them metformin for 12 months, or giving them intensive basal insulin therapy for 3 months, followed by 9 months of metformin, and then the 3-month washout, despite these interventions, the kids' beta cells deteriorated while on therapy and after washout even further, which was a completely different response to what we saw in adults, where we saw that they basically maintained their beta cell function with therapy, suggesting again that the pathogenesis of type 2 diabetes in these youth is different. Now, why is this a problem, you might argue? Well, in my view, what we've seen is an epidemic of type 2 diabetes in adults. And I think if we just look out to the horizon, there's a type 2 diabetes epidemic in youth occurring. And as an example, if you take Native Americans living in the US, 10 years period of time, the rate of development of type 2 diabetes in this youth has tripled over the period of 10 years because of obesity. And every racial ethnic group in the US, with the exception of Caucasians, we're seeing an increase in the incidence of this disease. And what we're seeing in the US, which we saw with adult type 2 diabetes as this thing evolved, then occurred everywhere else in the world, including in Asia, where everybody said, well, we're not going to get this disease. I think what we're seeing in the US, sadly, now with youth is just a premonition of what's going to be happening in a youth everywhere around the globe very shortly. And the International Diabetes Federation, all these organizations are going to start talking about the incidence and prevalence of diabetes in youth, just like they would do these surveys all the time for adults. And when I say youth, I'm talking specifically about type 2 diabetes, not type 1 diabetes, which we clearly recognize is very prevalent in kids.
So I imagine that you're going to be spending rather a lot of time on beta cells in youth for possibly quite some time yet. I mean, it's an area of intense research activity, I imagine, for you and for others.
Absolutely. And interestingly, the beauty of the way we designed the study to do it was that we've stored a lot of blood samples and we'll be making additional measurements on them. So, for example, we are completing the analyses now looking at glucagon as a measure of alpha cell function to see whether there's a difference in how youth and adults secrete and modulate glucagon, because we know in type 2 diabetes in adults that basically the dynamics of the alpha cell or the function of the alpha cell is different in people with type 2 diabetes than those without. And so now comes the question, is it different in kids to adults or the same? And those data we're hoping to generate and publish within the next 12 months. But that's just one of the analyses we're going to do. We have a host of other measurements that if we have enough money, we're going to make and be able to inform people a lot more about what's going on. But not only that, I think inform ourselves and I hope younger investigators who want to take this problem on and try and help us resolve what the problem is.
I can see an awful lot of great research coming out of your labs for quite some time yet. And I was very struck by something that you said at the beginning of your lecture about Claude Bernard himself, his philosophy about research, and that if something looked wrong, then you need to investigate it, basically, that you shouldn't just go with accepted wisdom.
Correct. I mean, I think that to me was really telling, because when we made those initial observations that I talked about with the beta cell and how it was defective, that was very contrary to what everybody was thinking. And he's basically, the way he put it was, the fact that everybody's chasing an idea or pushing forward an idea because they believe that's right doesn't mean to say you shouldn't challenge the idea because you think there may be an alternative. And that's exactly what we did. So don't just accept what's out there. And for me, that was how my career has been all the time. You're looking for new things that you can inform on. You want to learn something so that it raises the next question. And for me, who's getting older and grayer, as you can clearly see, my hope is there will be young people who want to take some of what we've done and move that forward, but also young people who are not following what we're doing, who will challenge what is in the literature and ask questions that can inform and improve health, particularly my personal interest in type 2 diabetes.
Fantastic. Thank you so much, Steve Kahn. And you can find the whole of the Claude Bernard lecture available online, and do watch it. It's absorbing, insightful, and a great tribute to a great researcher. Thank you so much.
Thank you very much.